Welcome to this case-based workshop on neonatal ventilation, focusing on the Drager Babylog VN500. We will cover 3 clinical cases: ventilator waveform interpretation, troubleshooting, and optimization. Our learning objectives are to identify the active ventilation mode, recognize artifacts and circuit problems, and optimize ventilator settings for neonatal physiology. This lecture was presented by me, Dr. Salem Keshba, a neonatal specialist.
Case 1 focuses on identifying the active ventilation mode. Here is the patient profile and the ventilator settings displayed. Note the teaching points for neonatal pressure control modes. CMV, pressure-controlled mandatory ventilation. All breaths are mandatory, time-cycled, pressure-limited. Patient cannot trigger breaths. Used in apneic, heavily sedated neonates. PCAC, pressure-controlled assist control. Every patient trigger receives full pressure support. Provides a backup rate if apnea occurs. Waveforms show mixed triggered plus mandatory breaths. PCSIMV, mandatory breaths synchronized with patient effort. Spontaneous breaths unsupported. PSV can be added.
Question 1 asks, what ventilation mode is currently active on this ventilator? Review the displayed screen and the mode tabs at the bottom. The correct answer is C, PCCMV. We know this because the mode tab shows a question mark, indicating an initial mandatory mode. Critically, the flow waveform is regular and uniform, suggesting all breaths are machine-triggered, which is characteristic of PCCMV. The pink arrows show mandatory breath, not patient effort.
Case 2 addresses hypocapnia and circuit artifacts. The ventilator shows active alarms for minute volume and respiratory rate high, with a rate of 98 per minute. However, the clinical context shows the PCO2 is very low. This section discusses how water in the circuit can cause false triggering, leading to autocycling, high rate, and hypocapnia. Water in ventilator circuit, condensation, acts as a false lung, causing spurious pressure and flow oscillations. The ventilator detects these oscillations as patient breaths, leads to autocycling, which in turn lead to very high RR and hyperventilation, and resulting to hypocapnia. Autocycling versus true tachypnea. In autocycling, the PAW waveform shows irregular non-physiologic spikes, circled in pink on answer slide. Flow shows irregular timing and amplitude.
Question 2 asks, the PCO2 is very low, and the RR alarm is firing at 98 per minute. What is the reason? Examine the PAW waveform for irregular spikes, a hint toward the cause. The correct answer is C, water in the patient circuit. The irregular non-physiologic oscillations, circled in pink on the PAW and flow waveforms, are caused by water droplets, triggering the ventilator repeatedly. The immediate action is to drain all water traps and check the circuit, expecting the respiratory rate to normalize. After the water was removed, there was a dramatic improvement. The waveforms are regular and alarms are cleared. The respiratory rate dropped from 98 to 39 per minute, a physiologically appropriate rate. This highlights the importance of checking for circuit water before adjusting ventilator settings.
Case 3 focuses on optimizing inspiratory time, TI. The patient is stable, but the actual respiratory rate is 56 per minute. The set TI is 0.30 seconds, which is at the lower limit for a 2.1 kilogram infant. The flow waveform clue suggests TI may be too short if flow is still high and not reach to 0 when the breath ends. Optimal TI for neonates. Generally 0.30-0.40 second for term, and 0.25-0.35 second for preterm. TI 0.30 second is at the lower limit for a 2,100 gram infant. IE ratio. With RR 56, cycle time equals 1.07 second. TI 0.30 second leads to IE approximately 1 to 2.6. Increasing TI to 0.35 to 0.40 leads to IE roughly 1 to 1.7 to 1 to 2. Improves alveolar recruitment without air trapping, if expiratory time adequate.
Question 3 asks, with a clear blood gas and a weight of 2.1 kilograms, what ventilator setting can be improved? Look closely at the flow waveform to determine if the delivery is complete. The correct answer is D, inspiratory time should be increased. The flow waveform shows flow is still positive at the end of inspiration, meaning the breath was terminated before complete volume delivery. Increasing TI allows flow to reach 0, promoting complete tidal delivery and reducing the work of breathing. Reviewing the waveform detail, The tidal volume of 9.9 milliliters per kilogram is within the acceptable range. However, extending TI will ensure complete pressure delivery and may slightly raise the volume. The 0% leak is reassuring that the displayed values are reliable. In summary, we covered 3 key areas. Mode identification, emphasizing the regularity of flow waveforms in PCCMV. Circuit artifacts, recognizing that water causes high RR and low PCO2, requiring trap drainage first. Finally, TI optimization, using flow waveform visualization to ensure complete volume delivery for better recruitment.